A very good afternoon, students, and we are here to begin with the first part of the specific antimicrobial agents, sulfonamide and sulfonamide combinations, co-triamoxazole. In my last session, we dealt with the general principles of antimicrobial use, which basically dealt with the classification of antimicrobials which we have. What is the difference between antimicrobial agent and antibiotic? You also read about the bacterial resistance and mechanisms by which the resistance spreads. And we also talked a bit about superinfection and antibiotic stewardship program. Now what is left is antimicrobial part 2, the principles, which is going to deal with the criteria for selection of an antimicrobial agent. That is going to be discussed. Second is that you would also be discussing what is the purpose of combining two antibiotics, which is a term which is called antibiotic synergism or antibiotic combinations, and what is the role of prophylactic antibiotic use or antimicrobial use, which are the indications where prophylactic antimicrobial use is satisfactory. And the last but not the least, we'll be carrying on the details of the antibiotic stewardship program. For that part has to wait until you have the knowledge of the specific antimicrobial agents, because unless you don't have the knowledge of the specific antimicrobial agents, you will not be able to understand the part 2 of the antimicrobial principles. So now the next 4 to 5 sessions are going to deal with specific antimicrobial agents, and to begin with we are going to talk about the sulfonamides and sulfonamide combinations, co-triamoxazole. A very good afternoon again to the students, and I am very hopeful that you have finally found peace and happiness at home, and this you need to continue even further, because that is what is preventing the spread of the virus in our country. In our country, the virus spread is not so phenomenal or not so difficult to handle as in countries like America or Italy. So we have controlled ourselves. We be positive that with this control and the restraint we are exerting on ourselves, which is very contrary to the human behavior, as I told, social distancing, we can win over this corona. So get up early in the morning, do a good exercise, study in the morning hours. Morning hours are very fresh to study. Have a little nap in the afternoon. In the evening, again study and watch something which you like on internet, TV or mobile. So students, divide your time of the day at home into something meaningful. If you do something meaningful, the day is well spent. If you don't do something meaningful, then you yourself will feel bored or strings of boredom will come to you. So let us be learning all the time. Let us be doing our duties which we are to do, but all in the confinement of home. So sulfonamides and sulfonamide combination, students, the combination is called co-triamoxazole. Sulfonamides. Let us start with a small story, that is when it was being first used. The country is Germany and the year is 1935. Hildegard, daughter of Dr. Gerhard Domag, is near death with a streptococcal infection following a pinprick. Now I told you in my first session that Domag was already studying the eradication of streptococcal infections on mice using the dye prontosol, using the azo dye prontosol. But then he himself was faced with his daughter's problem, so nothing could hold him back. You know, fathers are very fond of their daughters, so in desperation, her father injects her with prontosol, a red azo dye, which he had been experimenting in his lab. So what happened after that? Miraculously, she made a complete recovery. And Dr. Gerhard Domag was awarded the Nobel Prize for the discovery of the therapeutic benefit of prontosol and azo dye in 1939. So that was a landmark discovery for which Domag was also awarded a Nobel Prize. Now the prontosol dye contains a chemical which is called sulphonamide. And the term sulfonamide is employed herein as a generic name for the derivatives of para-aminobenzene sulfonamide, sulphonamide. Now what does these sulfonamides do? These sulfonamides do nothing but they inhibit the folic acid synthesis of the bacteria. That is what they do. And folic acid synthesis in the bacteria is very, very important, because once folic acid is formed, it gets converted to dihydrofolic acid, and from dihydrofolic acid it gets converted to tetrahydrofolic acid, students, and this tetrahydrofolic acid is responsible for thymidylate synthesis, purine synthesis, and 1-carbon transfer reactions. If this is not formed, then the bacteria are going to head for bacterial death. So that is what the sulfonamides do. Although the sulfonamides are not bactericidal in nature, they are classified as bacteristatic. But yes, the combination of sulfonamide with trimethoprim becomes cidal. Let us go further. As far as the mechanism of action of the sulfonamides go, in many microorganisms, the dihydrofolic acid, which is DHF, dihydrofolic acid, is synthesized from para-amino-benzoic acid, pteridine, and glutamate. So these are the products which are required to synthesize the dihydrofolic acid in bacteria, which further gets converted to tetrahydrofolic acid, the usable form of folic acid. Now all these sulfonamides which we are going to read, they will be classified as short acting, medium acting, and long acting, which are in current use, are synthetic analogues of PABA. They are synthetic analogues of PABA. That means instead of PABA getting incorporated to form dihydrofolic acid, they will get incorporated. Because of their structural similarity to PABA, the sulfonamides compete with their substrate for the bacterial enzyme dihydropteroid synthetase. Remember, P is silent here. It is called dihydropteroid synthetase. Thus, they inhibit the synthesis of bacterial dihydrofolic acid, and thereby all the subsequent steps, including the formation of essential cofactor forms. So in a nutshell, the sulfonamides inhibit dihydrofolic acid by being the structural analogues of PABA. Now this is one picture is that of PABA, that is the top picture is structure para-amino-benzoic acid PABA, which is used for the synthesis of the folic acid precursor dihydrofolic acid, and the other is the chemical structure of sulphanilamide. You can see the similarity between the two, and instead of PABA getting incorporated to form dihydrofolic acid, it is sulphanilamide which gets incorporated, and sulphanilamide also binds to the enzyme dihydropteroid synthetase and inhibits its action. Is it clear to all of you? Let us go further. As I told you, this is what is happening in the microorganisms, and this is what is happening. This reaction is happening in humans and microorganisms. If we just concentrate on the microorganism here, the bacteria, the pteridine precursor along with PABA, along with glutamate is required for the synthesis of dihydrofolic acid. And this happens under the influence of the enzyme dihydropteroid synthetase. Now this dihydropteroid synthetase is competitively inhibited by sulphanilamide and other sulfonamides, the antimicrobials in question. And once this enzyme is inhibited by sulphanilamide, because sulphanilamide has a very strong structural resemblance to PABA, so as a result dihydrofolic acid is not formed. Students, it is not formed. So if dihydrofolic acid is not formed, neither is dihydrofolate reductase able to convert dihydrofolic acid to the ready usable form of folic acid, tetrahydrofolic acid, and neither do these important things happen then. Neither acid synthesis occur in the bacteria, neither does the purine synthesis happen, neither does the thymidine synthesis happen. So this is a block here by sulfonamide. And since we are reading the human part also, humans take the dihydrofolic acid from the dye. They don't synthesize their own dihydrofolic acid. That means they don't have this enzyme dihydropteroid synthesis. It is of no use in the humans. But what enzyme is common between the microorganisms and the humans is dihydrofolate reductase. Because dihydrofolate reductase is present both in humans as well as microorganisms, which convert dihydrofolic acid to tetrahydrofolic acid. So if this tetrahydrofolic acid is formed, there is going to be adequate purine synthesis, there is going to be adequate amino acid synthesis, there is going to be adequate thymidine synthesis. Now DHFRase, that's called dihydrofolate reductase, is inhibited by another antimicrobial agent in the bacteria. The name is trimethoprim. So if we say sulphanilamide and trimethoprim block the folic acid synthesis pathway, we are correct, because both the drugs are producing sequential block. You know, if sulphanilamide is given, it's not that dihydrofolic acid will not be formed at all. Some parts, whole of the enzyme will not be inhibited. There will be some enzymes which will still be active and they will form dihydrofolic acid. So if you give trimethoprim, sulphanilamide and trimethoprim combination, or sulfonamide and trimethoprim combination, it is going to form, it is going to inhibit the enzyme synthesis of folic acid in two steps. One is the conversion of the pteridine precursor PABA into dihydrofolic acid. This enzyme is inhibited in the microorganism. This enzyme is also inhibited in the microorganisms by trimethoprim, and that will lead to complete suppression of the active form of folic acid. Now in the humans also there is this enzyme is present, which is DHFRase, and this enzyme in humans is not inhibited, students, by trimethoprim. So thereby trimethoprim exerts selective toxicity. This enzyme is inhibited by the anti-cancer agent methotrexate. Methotrexate is one anti-cancer agent which is going to inhibit the dihydrofolate reductase in the humans. Is it clear? So that's it. Now this is the other thing which is shown, the same thing, that PABA gets incorporated via the enzyme dihydropteroid synthetase to form folate or dihydrofolic acid, and this folate is converted by dihydrofolate reductase, which is inhibited by trimethoprim in the bacteria and methotrexate in the humans, to tetrahydrofolic acid, which is responsible for synthesis of thymidylate and subsequently DNA synthesis. So that is the mechanism action, students, of the sulfonamides. And sulfonamides can be divided into three major groups. One is oral absorbable. Second is given orally but not meant to be absorbed in the gut, is non-absorbable. And third is to be given topically in the form of creams. And we have three such forms of sulfonamide. You can classify them into oral absorbable, oral non-absorbable, and topical. Now the oral absorbable definitely are meant for systemic use, and we can divide them into three again. Short acting, which is only one drug which is available, sulfadiazine, which is available 4 to 8 hours is its duration of action. Intermediate acting, we have 8 to 12 hours, sulfamethoxazole. The sulfamethoxazole is the sulfonamide which is combined with trimethoprim, and the long acting sulfadoxine. There is another long acting drug which is available not in all the countries, sulfamethoxypyrazine, but yes, you can just remember sulfadoxine from the long acting class. And then we have some special purpose sulfonamides. One is sulfur, sulfadiazine and mefenide, which are meant to be applied on the skin. Then we have sulfacetamide, sodium, which are the eye drops, and you know they are commonly available as a brand name Locula. And sulfasalazine, which is meant for ulcerative colitis. And you know this is a type of a sulfonamide which is oral non-absorbable. You know it is classified under oral non-absorbable. I told you it can be classified oral absorbable, in which we had the three types: sulfadoxin, sulfadiazine and sulfamethoxazole. Then we have oral non-absorbable, which is meant to be given orally, but it is not absorbed in the GIT. It is meant for its local action. And what local action? I just let you know. And topical use. Topical ones are the ones which are given on the eye or applied on the skin. So this classification is actually trying to merge everything. You can see here, oral absorbable for systemic use is short acting 4 to 8 hours sulfadiazine, intermediate acting 8 to 12 hours sulfamethoxazole, and long acting sulfadoxin. And these are all meant for oral use for absorption. And then we have the special purpose sulfonamide, silver sulfadiazine mephenide, to be applied on the skin for topical use, sulfacetamide again to be applied topically in the eye, and sulfasalazine, which is oral non-absorbable. Students, remember this. This is oral non-absorbable, meant for local action on the colon in patients who are suffering from inflammatory bowel disease, ulcerative colitis. Now coming again to the mechanism of action, I told you sulfonamides are antifolates in nature. They are structural analogues of PABA. They competitively antagonize PABA. They exert selective toxicity because humans don't have this enzyme, which is dihydroteroid synthetase. They just have the DHFRase, which is inhibited by trimethoprim and methotrexate. So this is what it is. And sulfonamides, they inhibit the dihydroteroid synthetase, and which helps in the formation of dihydrofolic acid. This dihydrofolic acid is converted to tetrahydrofolic acid by the enzyme dihydrofolic acid reductase enzyme. And this tetrahydrofolate is very important. As I told you, it's a nucleoside precursor. PABA as such is very rich in pus and tissue breakdown products. So in an environment like this, the sulfonamides are rendered ineffective because, you know, they are structural analogues of PABA and they are competitive antagonists of PABA also. So if PABA is more, then they will not be able to inhibit the dihydroteroid synthetase. I told you competitive antagonism is always surmountable and is reversed by increasing the concentration of the agonist. So they are competitive antagonists. Now as far as their antibacterial spectrum is concerned, students, they don't have a narrow spectrum, they have a very broad spectrum. Sulfonamides are broad spectrum in nature, but at the same time they are not cidal in nature, they are bacteriostatic in nature. But they have a large spectrum. Let us go to the spectrum. They have a spectrum against both gram-positive and gram-negative bacteria. Of course, they are bacteriostatic, and the bacteria which they primarily inhibit are Streptococcus pyogenes, Streptococcus pneumonia, Neisseria meningitis, although they do not remain the drug of choice for any of these conditions. Haemophilus influenzae, if they can still be used. Nocardia, which causes opportunistic chest infections, Chlamydia trachomatis, and some protozoas. The sulfonamides are still very effective. They are also effective for some enteric bacteria like E. coli, which causes urinary tract infection, Klebsiella, which causes nosocomial infection, Salmonella, which causes typhoid, Shigella, which causes dysentery, and these organisms will respond to the sulfonamides. It is interesting that rickettsia are not inhibited by sulfonamides but are actually stimulated by their growth. Rickettsial group of organisms, they cause rickettsial fevers, Rocky Mountain spotted fever, scrub typhus fever. Tetracyclines are the drug of choice for rickettsia. Sulfonamides are no longer not effective for rickettsial infections, although they are effective for the other atypical infection, Chlamydia trachomatis. Its activity is very poor against the anaerobes. Now students, when you start reading the antimicrobial agents, there will be a huge spectrum of bacteria written against each antimicrobial agent. But it is very difficult to remember that this particular antimicrobial agent is going to act on this particular bacteria. So it is very difficult for the students to actually remember the antibacterial spectrum. So what we can do is in a reverse way. You can have the uses of the sulfonamides first, and based on those uses or based on those infections in which they are used, you can correlate or extrapolate it backwards to the bacteria against which they are primarily active. You can forget the other bacteria. Nobody is going to punish you. Is it clear? The sulfur drugs or the sulfonamides are seldom prescribed alone. They are not used alone. They are always used in combination with the sequential blockade with trimethoprim, except in developing countries where they are still employed because of their low cost and their efficacy in certain bacterial infections such as trachoma and urinary tract. So let us go further. Sulfonamide resistance is also very commonly seen, and it is because of decreased affinity of sulfonamides for the enzyme dihydroteroid synthetase. That means the targets gets altered. There is less bacterial permeability of the drug inside the cell or active efflux of the drug outside the cell. So that could be one of the reasons. And there can be, this is the most important thing, that the bacteria which have become resistant to the sulfonamides have developed alternative metabolic pathways for synthesis of folate. That means they might have been taking the folic acid, which is, as the humans are doing, taking from the diet. So herein the sulfonamides would be rendered ineffective. Or the bacteria which have become resistant will try to overproduce PABA. So if their PABA production is more, then the competition which is there for sulfonamides for occupation of the enzyme dihydroteroid synthetase is much more. In that case, sulfonamides will not be effective. Some resistant bacteria, staphylococcus-like bacteria, may synthesize 70 times as much PABA. So this could be the possible mechanisms of resistance, but yes, this is the most important mechanism, that there could be alternative metabolic pathways for synthesis of folate, that bacteria is no longer synthesizing its own folic acid. Now coming to again to the classification of the sulfonamides. So a sulfonamide is oral absorbable for systemic use, short acting sulfadiazine, intermediate acting sulfamethoxazole students, long acting sulfadoxin and sulfamethopyrazine, and special purpose. Sometimes you might be asked a note on special purpose sulfonamides, which are silver sulfadiazine and mephenide, which are applied on the skin for prevention of infections. Sulfacetamide sodium, which is given for bacterial infections in the eye in the form of conjunctivitis, and sulfasalazine, which is given for ulcerative colitis. As far as the pharmacokinetics of sulfonamides go, they have a very good passage across the blood-brain barrier. They are very lipid soluble. They are well absorbed orally, and they are acetylated in the body. Remember this, that sulfonamide students are acetylated in the body, and acetylation is a process which undergoes genetic polymorphism. That means in the population there are fast acetylators and slow acetylators. So slow acetylators would require lesser dose of sulfonamides. Fast acetylators might require larger doses of sulfonamides, and there are other drugs also which are acetylated in the body. For example, isoniazid, for example, dapsone, for example, procainamide. These are all the drugs which whose metabolism will be affected by the presence of the enzyme N-acetyl transferase, which might be more in some individuals and which might be less in some individuals, making them extensive metabolizers, rapid metabolizers, or poor metabolizers or slow metabolizers of the drug. Students, they have a good protein binding capacity from 20 to 90%, so much so they could be responsible for some plasma protein binding displacement interactions. And the product of metabolism, the acetylated product of metabolism, is not active as far as antibacterial action is concerned, but it retains a toxic potential to precipitate at neutral or acidic pH. So the sulfonamide crystals, are formed in the neutral or acidic pH, and they behave as if there is an obstructive nephropathy. They behave as if there is a stone formation, and therefore there is a potential damage to the kidney, which is expected. This is more seen with the older sulfonamides, less seen with the newer sulfonamides, but nevertheless anybody who's taking sulfonamides should see that the urine is alkalinized. It is not acidic, because acidic pH favors the development of these crystals, which could be harmful to the kidney in the long run. They may precipitate stone formation. Now, sulfioxazole and sulfamethoxazole, the intermediate acting sulfonamides, are exclusively used to treat urinary tract infection, and the dose is 1 gram 2 to 3 times a day. Nobody is using this, rarely used now. But yes, the sulfadiazine, sulfadiazine is a shorter acting sulfonamide with a half-life of 6 to 8 hours. It is used in combination with pyrimethamine as a first-line therapy for the acute toxoplasmosis. Acute toxoplasmosis is a plasmodial infection. It it behaves as a space occupying lesion in the brain. The Toxoplasma gondii is the organism which is responsible, and sulfadiazine along with the pyrimethamine is the first line treatment for such organisms. Sulfadiazine, pyrimethamine are also going to produce a a sequential block, as sulfamethoxazole and trimethoprim are going to produce a sequential block. Similarly, sulfadiazine and pyrimethamine are also going to produce a sequential block. Pyrimethamine is going to block the DHFRAs of the plasmodium, which is dihydrofolate reductase, and sulfadiazine is going to block the dihydropteroid synthetase. So this is an example of a sequential block. Another one is sulfadoxin, which is used for malaria. It is the longest acting sulfonamide preparation available with a very long half-life of around 24 hours. It is used in combination again with the DHFRase inhibitor, pyrimethamine. The combination is called Fancidar, and it is used as a second-line agent in the treatment of malaria. It is used for resistant malaria where chloroquine is not working. It is used as a second-line agent, not as a first-line agent. So if you gather the uses of sulfonamide, they are used alone only in preparation or in uses for urinary tract infection. And another condition, sulfadiazine, which is a shorter acting sulfonamide in combination with the pyrimethamine for acute toxoplasmosis, sulfadoxine with pyrimethamine again for the treatment for malaria. We are yet to read sulfamethoxazole and trimethoprim, which is an antibacterial combination. These are all the combinations which are meant to eradicate the plasmodial species, both toxoplasma and as well as malaria. For that we will be taking up later, but just you should know what are the examples of sequential block. So I would not be wrong if I say sulfamethoxazole and trimethoprim for bacterial infections, sulfadiazine and pyrimethamine for acute toxoplasmosis, sulfadoxin with pyrimethamine for malaria. Students, sometimes this short note is asked sequential blockage, so you should be able to answer this. Now coming to the untoward reactions to sulfonamide. Sulfonamide do cause lots of untoward reactions, so we always take patient's history before we prescribe sulfonamide. By आपको sulfa allergy तो नहीं है. Sulfa allergy means sulfonamide allergy. So the most common reaction which we give with sulfonamides is sulfonamide allergy, what you call sulpha allergy. It can range from a rash to erythema multiforme to Stevens-Johnson syndrome to toxic epidermal necrolysis. Students, sulfonamides can cause this type of drug hypersensitivity reactions also, and it is very common with sulfonamides to have these kind of skin reactions. But let us have the untoward reactions to sulfonamides. I told you the sulfonamide crystallizes especially in the acidic urine, and this forms crystals in the urine. These crystals can behave as renal stones, and that can cause obstructive nephropathy. So we can prevent that by instructing the patient to have large amounts of water when he is taking sulfonamide. You need to alkalize the urine also if required. Acidic urine precipitates the formation of such crystals. So if the urine is neutral or slightly on the alkaline side, it will form less of such crystals. This problem was seen more with the older, less soluble sulfonamides, very low with more soluble agents like sulfioxazole. And in dehydrated patients with AIDS, Toxoplasma gondii is an opportunistic organism. Toxoplasma encephalitis can cause. It can manifest as a space occupying lesion in the brain, and it is more seen as an opportunistic infection in patients of AIDS. So the sulfate group of drugs may not be given to routine population, but it is definitely reserved in patients who are having AIDS and who have these opportunistic infections like toxoplasmosis or pneumocystitis girovecii. We are just going to come to that. Measures to prevent this crystalluria are simple. Use newer soluble agents. Fluid intake should be large, minimum 1200 ml in adults, and alkalization of the urine is favored here, and this is how you would be able to take care of this crystalluria, which can happen more with the older sulfonamides, less with the newer sulfonamides. Students, some of the adverse effects of students of drugs can be minimized, some cannot be minimized. You remember one thing, and There are some effects of sulfonamides which cannot be minimized, and those are the risk on the hematopoietic system, the risk of causing skin adverse reactions. Now the hematopoietic system suffers a lot. We say sulfonamides are having selective toxicity, but they do inhibit the folic acid synthesis in the mammalian host cell also to some extent, and the effects are there on the hematopoietic system. There can be complete suppression of the bone marrow or suppression of individual bone cell elements, and this suppression of the hematopoietic system is seen more if the patient is coexistingly having AIDS. Skin reactions with sulfonamides are more in patients who are having AIDS. Hematopoietic system abnormalities are also more in patients who are having AIDS. It can also present itself as acute hemolytic anemia, and this is due to the deficiency of G6 phosphate dehydrogenase activity in erythrocytes. Patients who are G6PD deficient, any oxidant drug, for example sulfonamide, for example dapsone, for example primaquine, for example chloroquine, if given in such individuals, can trigger bleeding and acute hemolytic anemias because of deficiency of glucose 6-phosphate dehydrogenase enzyme. This enzyme is very important for maintaining the RBC integrity, the membrane integrity. So this, if this enzyme is deficient genetically in such individuals, any oxidant drug which is given is going to cause lysis of the RBC membrane and going to cause acute hemolytic anemia. So patients of G6PD deficient individuals should not be given sulfonamides at all. Agranulocytosis is another important abnormality on the hematopoietic system, and recovery can be delayed for weeks or months, and after sulfonamide is withdrawn. It can also cause complete bone marrow suppression in the form of aplastic anemia, which could be dangerous. It can also individually suppress the bone elements in the form of granulocytopenias and thrombocytopenias. This aplastic anemia is reversible. When we talk about this, we are comparing and contrasting with one of the drugs which we are going to study soon, is chloramphenicol, which sometimes can cause irreversible bone marrow suppression. As far as the hypersensitivity reactions are concerned, they are most common. Students' skin and mucous membrane are terribly involved. It can be in the form of morbilliform, urticarial, pemphigoid-like rashes, purpuric rashes, red rashes, erythema nodosum, erythema multiforme, that is exfoliation of the skin and the mucous membrane, which is a type of a Stevens-Johnson syndrome. And this is a life-threatening syndrome which can happen with many drugs, including sulfonamides, including the anti-epileptic drugs like phenytoin, carbamazepine. Lamotrigine is also one of the anti-epileptic drugs which is associated with Stevens-Johnson syndrome. Many NSAIDs, you know, they are associated with Stevens-Johnson syndrome. This is some type of a drug emergency or ADR, emergency adverse drug reaction. The patient needs immediate withdrawal of sulfonamide and attendant treatment. It is also characterized by exfoliative dermatitis, photosensitivity, that if you go out in the sun, there is a rash if you are on sulfonamide therapy. Drugs can also cause fever. You know, there's a term which is called drug fever. Sulfonamides can cause drug fever. Many other antimicrobials like fluoroquinolones can cause drug fever. Ciprofloxacin, levofloxacins are responsible for drug fevers. Drug fever is a type of a constant fever around 100, 101. And when a patient you are tackling very well in the wards, his WBC counts have fallen, your infection, you are taking care of this infection, suddenly there is a fever which starts, which has emerged after a few days of hospitalization. Everything else is going on well with this patient, but he has a fever. You are doubtful what it is, what have I missed, what's gone wrong. The thing is, it could be a plain drug fever. Students, this happens commonly in the ward. This type of fever is not high grade in nature. It is a continuous type of fever, and it is a drug fever. It's a type of a drug hypersensitivity reaction. This is a type of the Stevens-Johnson syndrome which can be seen in patients. You can see extensive skin and mucous membrane involvement. This is life-threatening, and there can be formation of some bullous also, bullae involving 10%, macropapules, and this is sometimes some picture which is also called toxic epidermal necrolysis. Stevens-Johnson syndrome drug. Students, you must remember the drugs which can cause Stevens-Johnson syndrome. The top of the list is sulfonamides, cotrimoxazole, anti-epileptics like phenytoin, carbamazepine, lamotrigine. Many NSAIDs, they can cause Stevens-Johnson syndrome. So there's some rare toxicities which are also seen. Less than 0.1% of the patients might present with hepatotoxicity, and that is characterized by vomiting, fever, hepatomegaly, jaundice, and this will appear 3 to 5 days after sulfonamide therapy is started. Syndrome may progress to acute yellow atrophy and death. So this can also be one of the things, complications. So coming to the contraindications for sulfonamide therapy, there are a few contraindications. Pregnant women near term, because these drugs, they pass through the placenta and they are secreted in the milk, and thereby they can damage the fetus, and yeah, the neonates, they have a lot of unconjugated bilirubin in the circulation, and this unconjugated bilirubin binds to the plasma proteins in the neonates, and if this unconjugated bilirubin is displaced from its plasma protein binding site, these unconjugated bilirubin is going to cross the blood-brain barrier and lead to a state of kernicterus, which is a mental encephalopathy. So sulfonamides are responsible for this mental encephalopathy in neonates and preterm babies, because it is going to displace the unconjugated bilirubin from its plasma protein binding site. Unconjugated bilirubin will now be free to cross the blood-brain barrier and to cause kernicterus. So sulfonamides are avoided in pregnant ladies, avoided in lactating mothers. These are the side effects of sulfonamides: crystalluria, hypersensitivity reactions, which are type 3 hypersensitive, not type 1. Type 1 is anaphylaxis. Type 3 is Stevens-Johnson syndrome, erythema multiforme, toxic epidermal necrolysis. It can also cause hemolytic anemia, as I told you, in G6PD deficient individuals, and it can cause kernicterus because of allowing the passage of the unconjugated bilirubin across the blood-brain barrier. There are some drug interactions also seen with the sulfonamides. They potentiate the effects of oral anticoagulants, because they might inhibit the metabolism of oral anticoagulants like warfarin. They might displace the hypoglycemic agents from their plasma protein binding site, especially the sulfonylurea type of hypoglycemic agents, which are basically having a structural similarity with sulfonamide. So this displays the sulfonylurea from their binding site. So more of sulfonylurea in the blood means more of enhanced hypoglycemic action. So patient who is a diabetic, who is on a sulfonylurea therapy, might face more episodes of hypoglycemia, and they might potentiate the effect of hydantoin anticonvulsants, the phenytoin-like anticonvulsants, because they will retard the metabolism of phenytoin, or they will retard the metabolism of phenytoin. So dose adjustment may be necessary when a sulfonamide is given concurrently. Sulpha moiety is present with not only in just the sulfonamides, but also present in other drugs like the loop diuretics, the thiazides, the carbonic anhydrase inhibitors, the diazoxides. What it is, a potassium channel opener used for hypertensive emergency, and is used for insulinoma and for hypertensive emergencies. Sulfonylureas, tolbutamide, which is a blood sugar lowering agent. Sulfones, dapsone, which also contains the sulpha moiety. The COX-2 inhibitors, which are rarely used now, celecoxib and valdecoxib, and the protease inhibitors, which are used for HIV, emprinavir and tiprinavir. They are having the sulpha moiety in themselves, and if there is an allergy with the sulfonamides, the patient might be allergic to these components or these drugs, which are not antibiotics actually. They are used for different indications, but you should inquire about drug allergy. That is the basis for inquiring about the drug allergy from patients. So you have sulpha allergy or not. So if the patient has sulpha allergy, just don't not prescribe sulfonamide, but better not prescribe any of these drugs also. Students, successful prescribing requires a lot of knowledge. It's not just taking out a pen and paper and putting down the prescription. It takes into account the disease status of the individual. It takes into account the allergies the patient has suffered in the past. And it also takes into account the other drugs patient might be receiving for other indications. So all these things have to be considered. We should not be so selfish that we just write our prescription and hand it over to the patient. We have to take out some time discussing with the patient what prescription drugs he is already on, and whether he has some allergy to some use of some drugs. So that will impart greater success of your prescription, students. As far as the therapeutic uses of sulfonamides are concerned, they have limited uses. I told you, urinary tract infection. Then for opportunistic infection like nocardiosis. Nocardiosis is an opportunistic infection which is seen if the patient is on long-term steroid therapy or who is an immune suppressed individual. Nocardiosis responds poorly to all antimicrobial agents. It's an atypical microorganism and it causes pneumonia. Nocardiosis is responsible for causing pneumonia, which is treated by aminoglycosides or sulfonamides for that matter, and it is a difficult condition to eradicate. And third indication for the use of is in the use of the toxoplasmosis, which is caused by the Toxoplasma gondii, where sulfonamides are not used alone, but they are combined with pyrimethamine and they are used as a treatment of choice. And pyrimethamine dose is loading dose of 75 milligram followed by 25 milligram orally per day. The dose of sulfadiazine is 1 gram per day for every 6 hourly, and 1 gram orally every 6 hourly, and you have to ensure good fluid intake so that there is no problem of crystalluria in patients who are taking toxoplasmosis. You know, these infections, students, nocardiosis and toxoplasmosis are opportunistic infections, and when you get a patient who would require a sulfonamide therapy, sulfonamides are no longer used for routine therapies. Now they are used for therapies for opportunistic organisms. You have to consider the status of the patient as a whole. What is the use of sulfonamides for prophylaxis? Sulfonamides are rarely used for prophylaxis except when patients are allergic to penicillin. They can be used for prophylaxis. Prevention of streptococcal infection and recurrences of rheumatic fever among susceptible patients who are allergic to penicillin. Penicillins, of course, are the drugs of choice for rheumatic fever and for streptococcal infections. But if the patient is having allergy to penicillin, has developed an anaphylaxis with penicillin, you will never be giving him penicillin, and you have to resort to other agents for the same. It is less preferred due to its toxicity, and should be used only in patients who are hypersensitive to penicillin. So that is the only prophylactic use of sulfonamide. Now we come to the topical uses of sulfonamide. I told you the special purpose sulfonamide, and there is a special purpose sulfonamide here is sulfacetamide sodium, students, and they are used for eradication of bacterial infections and inclusion conjunctivitis, which is caused by Neisseria gonorrhea in children, and trachoma, which is most responsive to tetracycline. But yes, topically we can give sulfacetamide sodium eye drops to the extent of 10 to 30%. They are available as locular eye drops. Even eye ointment for sulfonamide is available, the sulfacetamide sodium. Then sulfonamides, remember students, one thing, is not used for the treatment of infections in burns. Not used for the treatment. What is the causative organism for infection in burns patient is pseudomonas. They will establish themselves as green colonies. So once the infection is set in, sulfonamides are not effective, but just for prevention, the preventive uses, prevention of infection in burn patients, silver sulfadiazine cream is applied 1% to the skin of the patient who has a burnt surface, and mephenide cream also for the same indication. Students, sulfur sulfadiazine cream and mephenide cream are used for prevention. They are not used if the infection has already set in. Remember this, because this infection which will colonize a burnt skin is a pseudomonas infection which will not be treatable by these agents topically. They have to be given anti-pseudomonas agents. Yes, but for prevention of infection it is given. For prevention of infection it is given. Remember one thing. Now let us consider this MCQ, students. Sulfonamide increase the risk of neonatal connectors because they diminish the production of plasma albumin? No. They increase the turnover of red blood cells? No. They inhibit the metabolism of bilirubin? No. They depress the bone marrow? They do depress the bone marrow, but that's not the reason they increase the risk of neonatal connectors. They increase the risk of neonatal connectors because they compete for bilirubin for the plasma protein binding sites. Bilirubin binds to albumin. Sulfonamides are also acidic drugs. They bind to albumin. They'll displace bilirubin, unconjugated bilirubin from its binding site, and that bilirubin will be able to cross the blood-brain barrier and produce neonatal connectors. So that is the reason that they should be avoided in neonates. They should be avoided in lactating mothers also. Now students, we take a break here, and we will be coming out with the sulfonamide trimethoprim combinations sooner, but I just want to tell you about the use of sulfasalazine, which I failed to discuss here. That is a oral non-absorbable sulfonamide. That will be useful for you because this drug is important for you. Yeah, this sulfasalazine. We have read about sulfadiazine. We are yet to read about sulfamethoxazole in my next session. We have read about sulfadoxine used for the treatment of malaria, sulfadiazine for the treatment of toxoplasmosis and nocardiosis. And we have read about the preventive role of silver sulfadizine and mefenide for prevention of infection on the burnt skin, sulfacetamide sodium for bacterial conjunctivitis and for chlamydia and for inclusional conjunctivitis in children especially, and sulfasalazine. This drug was missed, students. Sulfasalazine is a special purpose sulfonamide. It is a drug which is used for inflammatory bowel disease, ulcerative colitis. Sulfasalazine goes inside, gets inside the person's body, reaches the GIT or reaches the intestine and the colon of the bacteria. It remains unabsorbed, reaches the colon, where it is split up by the colonic bacteria into sulfapyridine and 5-aminosalicylic acid. Now this 5-aminosalicylic acid is an anti-inflammatory. You know that salicylic acid is anti-inflammatory. Similarly, sulfasalazine gets converted to 5-aminosalicylic acid and sulfapyridine. 5-aminosalicylic acid is going to take care of the inflammation in the colon, which are the trademark of inflammatory bowel disease, like ulcerative colitis. It's not the only drug which is available for ulcerative colitis. We have other drugs for ulcerative colitis also, and because it's an autoimmune disease, it has other drugs which we are going to talk about. This is not the present lecture is not to deal with that, but just want to tell you about the special purpose sulfonamides, students. So we will be recapitulating the other things later, students, and we wind up here for the second session. Is going to follow very soon.